popote pale, na mimi napatikana huko Kirinyaga. Asanteni.
Thank you very much. Daktari.
Good afternoon. Dr. Thuranira everywhere.
Kuna daktari mmoja amepotea, Dr. Mwai atarudi. Thank you very much. Now I introduce the government spokespersons, deputy spokespersons.
Asante. Niaje? Mumetuliz. Muko mufti. Muko powers. Mbona mwingine ule jamaa tu amenifurahisha, ni jamaa ule wa New Guinea. Nyinyi kwani mmepitia reba wapi? Wacheni Oristo. Naitwa Gabriel Muthuma, naibu msemaji wa serikali. Nimefurahi kuona. Karibuni.
Hamjambo nyote. Mimi kwa majina Mwanaisha Chizuga, naibu msemaji wa serikali. Mwanaisha Chizuga kila mahali, popote pale, ingawa vingine vile vile sijui kuvitumia, lakini nipo mumo. Karibuni.
Thank you very much. And now I introduce the head of President's Special Program, Secretary of Office of the President, Mr. Dennis Itumbi, who will then introduce us to the spokespersons.
Hi. Mko fiti? Mimi leo nimekuja kusoma. I still don't like this format. I don't know why. Is it because of the training? I don't understand. Me, I like the circular one. Si hapa mwisho ya sako tunaweza weka hii board bado. So everybody will still see. Because this one now I have to struggle when you're introducing. We don't even know each other. Fadhali ile tunaangaliana. Sio? So situfanye hivyo. To move kiti, tuifanye circular. No reason to fight. I sincerely don't want to be government spokesman. I see what you guys do. So you pass that message for me. Having said that, I sincerely appreciate that you have continuously created time for us, even when you are very, very busy schedules. I totally don't take it for granted. Thank you very much. As you go around, I've seen you started going around to these hospitals. Please tell us, ndio tuwapatie backup. When you are going somewhere, we can always give you five people among us to go with in those areas, so that then they also get exposed on the actual terrain. The same applies to you, Doctor. When you have something you're doing out there, you have a team. Why I invited you guys here, I wanted you to see, unajua tunasemanga tu tuko na team, but you have never actually put faces to it. In fact, not even everyone is here. We have a big team. So this team is not mine, it's our team. So please use this team as much as you can. Terry's hapa, as long as you have his contact, you have access to this team. So that then, hata kama kuna message mnataka ipass, ama kuna kitu mnataka spread, these are the guys. And also mkilimo sana kwa hizo pages zenu, you have Terry's here, ataambia watu they will come to your defense. Lakini kulimo pia ni sawa. Some ingine don't even involve them. Limo so that you also get the true picture out there. Then now as we sort those problems, you are able to know what to do. Having said those preliminary bits, I invite Dr. Thuranira and Dr. Mwai have been working on this thing for us since campaign time. So when we got in, they just continued with something that's in their heart. So when I asked them to please to come and help train us, to tukienda to defend, to spread to poster, we are putting something we believe in. Please take notes from your phone or somewhere. Let's go and interpret these things for social media, depending on what you have understood. They would take the next, I'm sure, 1 hour, and I'm sure they prefer a lot of questions more. So hizo maswali zote unauliza huko kwa social media, today is your day. Ask them, and let's do. Then after they finish, we will ask the government spokespersons to also just tell us what maybe gaps may have been left, and they will also address us. And then after that, to funge, so that we also allow you guys to travel and prepare for next week. Thank you very much.
So the first thing, if they tell you about Adani, you show them the manifesto. Because our backup, very good. Now, basically, when we came up with the manifesto, teams were called in to start working on an implementation matrix. And fortunately, the president sat through all these meetings. He had to give you the go-ahead to implement that. So 17 meetings after, we were told implement now. So mnaenda mnaambiwa iko sawa. Now, we came up with a very good roadmap of how we will implement this one. But the first thing we realized, political goodwill, while His Excellency the President has political goodwill, his term will come to an end. His second term, somebody else will come. So the best thing is to anchor things in the law. So we came up with 4 laws. And they went through Parliament just to provide an anchor for the new service delivery. And the 4 laws are, number 1, Facility Improvement Financing Act. So this is an act of Parliament to enhance ring fencing of finances in the facilities. So pesa ya healthcare inabaki pesa ya healthcare. Did you read something like that in the manifesto? So that act is just to anchor that, so that whatever money is collected, currently what happens, they collect money, wanapeleka kwa county revenue account. They use health as a money collection for the county, then they use it to do other things. So we want monies for health to remain as health. So that's the first act. So we locked that one. Manifesto, first thing, tick. Second thing, Primary Healthcare Act. The Primary Healthcare Act is basically to govern the delivery of healthcare services in level 2. Level 1 being community, level 2 and level 3 facilities. So how the dispensaries work, how the health centers work, but more importantly, how the community health promoters work. Remember, His Excellency flagged off 100,000 CHPs. How many of you have seen them? They go around with a red bag, they have a reflector jacket, they come to your household, take some few details, they have an electronic phone, then they take your blood pressure, blood sugar and everything. The third one is called the Digital Health Act, just to govern how health data is managed. So this is specific for health data, because there is data being collected by a community health promoter, there is data being collected in a hospital, there is data we are collecting when you are registering you into SHA, just to govern that space. And this governs this whole entire digitization scope. The last one is what we call the Social Health Insurance Act. Social Health Insurance Act is what came to repeal or do away with NHIF. So the question starts, why did you have to do away with NHIF? Why did you bring in a new thing and not do away with NHIF? Now, the benefits were a bit too structured and too small. Then there were so many other issues of, we wanted to create different funds within it. So the issues that we required, and actually when it came in, we tried to amend it. And the advisory we got from the members of parliament is that what you are doing is a totally new thing. So the best thing is draft a new thing, put all the good things, remove the bad things from experience, bring in a bill that is passed. So we did that act, and the act passed, and we did the benefits, the regulations, and we finished. But now a summary of this act established something called the Social Health Authority. So SHA, now let me start making things like, SHA is the body, the institution. The former institution was called NHIF. The new one would be called SHA. It's called SHA. So under SHA, it has 3, Waswahili husema iko na mifuko mitatu. Inaisha. Is that entirely correct? I think I've corrected. So mfuko mmoja unaitwa primary healthcare. Primary healthcare ni mfuko ambao pesa ikitoka kwa serikali. Hii pesa italipa kwa matumizi ya afya kwa zahanati. No, level 3. Health center. Yes. Vituo vya afya. So dispensary and what? Health center. I want for you to understand this thing. I come from Bomet. Remember where you come from. Remember that dispensary. Remember that health center. So both private, public, and faith-based. If you go seek services there, it's a walk-in, walk-out. You'll be treated, you go home. How do you qualify to go and seek services there and enjoy these services? You just need to register. Ukijiandikisha tu hivi kwa SHA, Unaenda hapo, wanaona umejiandikisha, unapewa huduma, unaenda nyumbani. Iko sawa mpaka hapo? Watu wengi sana ukosa kwenda kwa hizi, they run away from going to these small level facilities, probably because of distance, probably lack of medication and everything, and they target the Kenyattas and everything. Now, mka unapeleka kohozi yako Kenyatta. You have a cough, you have a cold, you have a headache, you do Kenyatta. So instead of Kenyatta doing what they are supposed to do, specialized services, we start dividing the human resource. Our specialized here. So they need to concentrate on their core mandate. So the best thing is you empower the lower level facilities to provide the service. Now, if you go to these facilities and you find, so service delivery starts at the community level, the CHP level. So the CHPs come to your home, they carry a bag, they identify themselves, they register you, they ask you if you have any problem. They have a BP machine, so you're entitled to a free BP measurement throughout your life. There's a free blood sugar machine. If we had asked for projection, I wanted to show you the statistics of what they have done. So far, they have done an amazing job. They have gone to 8.5 million households. Then umeingia boma 8.5 million. Your boma iko na watu minimum of 3 to 5. So they might have seen in excess of 35 million Kenyans. That is impact. That's Dr. William Ruto's project legacy program. They're going to say, wameenda wameguza watu. Now after that, they find you have a problem, they refer you to the nearest facility, the nearest level 2 or level 3. You land there, matibabu hapo pia ni bure. Umelipiwa na nani? Serikali. The only thing you need to do bibi ama bwana, watoto, then ufanye atantumia kizungu sijui inalitoaje. You do means testing. Means testing is just an assessment of your ability to pay. So on this model, we are assessing your ability to pay, and we tell you pay this amount. Ile ingine ilikuwa imekaa ikasema hawa ni maskini, hawa lazima walipiwe, hawa wengine hawajiwezi nini, hawa ni wa 500, hawa ni you understand? This one we are giving it to you. We assess you and you tell us your ability to pay. Unaelewa? Na kuna wengine wenu wamefanya means testing, so mtatuambia majibu yenu. Kisha, so you pay that, you go to a facility, that one is used. So in a level 4, level 5, and a level 6. Now, kuna mfuko mwingine tuliweka. Mfuko unaitwa Emergency, Chronic and Critical Illness Fund. Mfuko wa 3. Now, emergency part. If you read the Constitution, Article 43(2) says that everyone has a right for emergency treatment. So they gave us that right. It's your right, by the way, to be given. No one has made that clause operational. Until this government came in, no one has ever made that clause operational. That clause means if you get a misfortune, an accident, something happens to you along the road. Previously, if the nearest hospital is a private hospital, you are brought here, and because no one will pay for that bill, see what I will do? I'll put a bandage here, I put a line, I put a drip, I put you in an ambulance, I take you to a government hospital. Is that true? Because that private hospital is a business. Let's not forget it is his business. If he gives you services and everything, that is his loss. But now we have put in an emergency fund for anyone, them not to deny you that service, because they have somewhere they can claim it, isn't it? So the entitlement to the emergency fund, it is a right. You don't need to register. That is a right we are giving any Kenyan. You understand? Hiyo ni right yako, ni haki yako. So ukipata ajali hapa, unaweka kwa ambulance, unakimbizwa hospitali, they stabilize you. We expect within those 24 hours, umeamka, we can identify you, you can talk to us, you can tell us where you come from, we can call your relatives, we can use your fingerprint to identify you if you are paid up for shift, such things, isn't it? Justification for 24 hours. Now, there's a second part of it called chronic and critical illness. Chronic and critical illness is where wewe ni mgonjwa wa sukari, diabetes, cancer, hypertension, the chronic illnesses. Sasa umetumia mfuko wako wa SHIF umeisha, lakini unahitaji dialysis third session. Kimo yako unahitaji maybe uende second line, pesa ya first line imeisha. Sasa ule mfuko ambao utatoka kwa pesa ya serikali, kwa ushuru wako, ndio sasa tutalipa. Tukimaliza hii tunaanza kula ule mfuko. You understand? It's a reserve pocket for you. So basically that is what is going on. So currently what are we doing? We are encouraging every Kenyan to register. First, to register to be able to access primary health care services. Number 2, to give us data for planning. But more importantly, to make you join the SHIF, pay and get additional benefits. How do you register? *147#. Lakini ukimaliza hiyo safari unaambia mtu haijaisha bado. Hiyo ni ile tu umejiandikisha kidogo. We want you to add your dependents. We want you to update your profile in your account. Take charge of your portal. Take charge of this registration process. Add your dependents, add your spouse, add your children, add everybody that you're supposed to add so that they all benefit from this. The problem is that Kenyans are only registering themselves. Nasikia mahali shida zinaanza. Sasa bwana akijiandikisha andikishi bibi. Bibi akijiandikisha andikishi bwana. So we have started encouraging them. So the message out there is that encourage people to register and add their dependents. That's number 1. So ukimaliza *147# unaambia watu, we encourage you. You get a prompt to tell you that to complete this journey, go to this. Ukiingia kwa mtandao www.sha.go.ke ama afyayangu.go.ke, unajiandikisha, unaweka details za bibi ama bwana, unaweka watoto. Kisha kama hujaajiriwa, unafanya these normal jobs or you have a casual kind of job, you do what we call means testing. Then at the end of means testing, we get to know what premium you're supposed to pay. Currently, kwa sababu ya hizi rollout challenges, tunakukubali ulipe ya mwezi moja kwanza, alafu upate huduma, lakini uko na siku 90 kulipa premium yote. Knowing Kenyans, So if you find and you're talking to somebody who has ability to pay, tell him to pay the whole premium. So najua we need sustainability. We need more money to run this program, isn't it? But wale wajiwezi, maybe alifika hospitali ya kona 500 tu. Lakini akilipa tu hiyo kidogo, anapata huduma zote. Lakini kwa sababu ya hizo huduma zisaidie mwenzake, aje alipe bili yake yote. Iko sawa mpaka hapo? Now, ukifanyiwa means testing, upate bei yako imepanda juu kidogo, hizi ni baraka zinakuja. Imepanda juu kidogo and you're not in agreement with that means testing result. There's a button written there, means testing appeal. Kwa hiyo registration tu kienda, unapata appeal, unafinya appeal. Utaulizwa maswali zingine, ulizwe nyumba yako inakaa aje, unaishi mahali gani, nini unafanya kazi gani, what is your average income, kwa hizi vibarua unafanya, then we'll give you a new figure. For now, it is reducing. There's a possibility in the revision. In these questions I'm asking you, I might detect that you are lying in the first part. Premium yako ipande. Si ishuke. Unajua the people are expecting it to kifanya appeal ishuke chini, si ndio? There's a possibility itapanda. Naona kama Dennis pale yake, naona ni kama nafaa kupandisha, si ndio? So basically that's the second part of it. So lastly, as I give Mwai a chance to say something, is what are we telling people? We are telling people, why should you join SHA? The second thing is, what are the benefits of SHA? So I've told you, what services are offered in a level 2, level 3? Most of them are outpatient services. Nakumbuka vile, toka nyumbani unaenda unaonekana, kuna homa, malaria, nini, unapewa madawa unaenda nyumbani. So level 2, level 3, mostly is outpatient. Some have inpatient services. Basic admissions, deliveries, ANC, admissions for children. Sana inafanyika level 2, level 3. Si ndio? Now, it's a population thing. So, unaweza ingia private, ingia faith-based, uingie ya serikali. Ile iko karibu nawe. Ukiingia kwa SHIF, kuna vitu tumebadilisha mingi. These are the benefits sasa. For patients with chronic illnesses, let's start with the dialysis. Renal, wagonjwa wa shida ya kidneys. Previously under NHIF, we were just paying for 2 dialysis sessions and transplant only for the patient. Now we are paying 2 dialysis sessions. The third session will be covered under the chronic fund for those ones that require. But more importantly, you might be a candidate for transplant. So you and your donor, the cost for screening you for those and screening you to be compatible, it's being taken care of. The surgery of both of you, it's surgery for 2 people. Huyu kungoa na kumstabilize na huyu kupewa. It's being catered for. Kisha huyu akipona anaenda nyumbani, kazi yake imeisha. Huyu, because you are receiving a foreign someone's organ, you need to take some medication. We call it post-transplant chemotherapy, ama anti-rejection drugs, so that the organ is not rejected. It wasn't covered in the previous NHIF. Now we are covering it. That's why you heard yesterday, Kenyatta did their first transplant patient under SHA. And he was in, actually they say today, he was on day 6 post-recovery. Understand? So people have started benefiting. Some of you have seen that clip. Still people have started benefiting out of it. That is dialysis. Sasa hiyo ni renal services yote. Oncology sasa. We are even paying for screening. We get to understand what, we screen you. No, we diagnose you. We get a final diagnosis. Then you start your chemotherapy. Previously, ulikuwa unaenda unajitafutia kidiagnosis huko, unakuja kuingia kwa mpango kutibiwe. So we are walking the journey with you. You understand? There's some few things we are finalizing on that part of oncology to make it even better and better for people. Linda mama, kina mama wakiwa wajawazito, walikuwa wanaenda hospitali, wanaenda 2 sessions, 2 to 3 sessions za clinic before siku ya kujifungua, wajifungua, wakienda nyumbani 2 clinics. Now, before and after delivery, the clinics are there. 6, 7, the frequency of how you want to do it. The tests for, we call it antenatal profile, inafanywa. Ukijifungua, whichever facility you go deliver from, it is being paid for. But more importantly, the Linda Mama program was taking care of the mother only. But now the mother is part of a household. So she comes in with a child, but there's a father of that child or the husband and the other children at home. So it's a household cover, okay? This one is not just targeting, these special entry groups we like, eduafia, watu wa kwenda shule peke yao. Then you pick expectant mothers. Linda Mama, expectant mothers only. Then you go to elderly, watu wazee peke yao. You understand? We are all in one society, we are all one. All of us are part of a household. So you look at that mother as a part of our whole household. We used to refund 2,500 to 3,500 for normal delivery, up to 10,000 to 17,000 for cesarean section. Now we are reimbursing 10,000 for normal deliveries and 30,000 for cesarean sections. Why? To give more money to this facility, to withhold that money, to be able to improve these facilities for better services. The more money they get, the more equipment they can buy, the more medication they can avail, and the more people they can hire. Okay? Mambo ya kulipa ati voluntary, hawa wanaamua kulipa wakati ni wagonjwa, hawa wengine wanalazimishwa kwa sababu ni employees wa serikali. That is long gone. Now we want all of us to be on board. My parting shot will be, there is so much that needs to be told about this story. I'll need like a full day to explain to you the things that we are doing. But I think that's a brief of where we are starting. So I'll give Mwai a chance to say something. Then you can take 2, 3, 4, 5, 6 questions. Can be directed to Dennis. He's the one who's answering questions. Okay, so Moi can say something, then we take questions. Then I'm seeing the blessings are coming. I don't want you to be rained on because of this exercise. Sawa? Thank you very much.
It's difficult to talk after Dr. Dronera has spoken, but I have spent my life in looking at challenges of the healthcare system within our countries. Countries hapa ni Africa, when we talk about the sub-Saharan Africa, for those who have looked at. But so beside what Dr. Dronera has said, I want to ask you, I'm sure mumekuwa kwa harambee za hospitali, si ndio? Na hizo harambee zinakuanga for what cases? If we can just hear from random illnesses, for instance, cancer, anything else? Kidney, what else? Heart surgeries, right? So when you want to help people, you start by asking yourself, where does it pain more? Sio swali ndio muhimu zaidi. Where does it pain more? Now, if you look at our social media, sometimes I look at it, na nimeona watu wamesema, oh, we have no benefit for meno. Sidio? Umesikia hiyo? How many times umeenda harambee ya meno? Nataka tu mniambie, unajua ni nzuri tujadiliane, because we have to do what is more important at a time like this one. Nataka mtu aniambie, sisi tulikuwa tumeitwa na our family tukatengeneza WhatsApp group, tutengeneze meno. Meno ilikuwa imeleta shida na tulikuwa kwa hiyo harambee. Now, why am I saying this? I'm saying this because we need to get rational, right? In being rational, sema shida kubwa ya health iko wapi? Na ni wapi unahitaji kusaidia mwananchi. Alright? Na tuko na shida moja kubwa. The first big problem is that helping a poor person is very difficult. Si mnajua hivyo? Hata yule MCA yenu muli-elect alikuwa maskini, sasa aliingia pale akakuwa rich, akasahau mambo ya maskini, akaingia mambo ya rich. Sindio? Because mechanism ile mulitumia, mulimpea kiti, akaanza kulipwa 1,800, huyo ni maskini ama ni rich? Yeah? Sio sasa yamekuwa rich. Now, akishavuka pande ya rich, the problem of he will be trying to solve are not of the poor. Sindio? Sababu mtu huwa na solve problem ya pale amefika. Alright? Now, what is the main characteristic of a poor person? Haelewangi vitu nyingi. Okay? Kwa sababu yule mtu anaweza muambia ni yule aliselect aende huko juu akuje amwambie. Now, if their intention is not to help that person, the poor person or the common mwananchi does not get the right information. Okay? So ukiangalia saa hii utaona mtu anakuambia we are not covering for all the things that NHIF was covering. Lakini mtu hakwambii NHIF was a private members club. Ama mnasikia kuna mtu ambaye si member alikuwa analipiwa? Yeah? So why are we not saying tuko hapa na fund moja, at least government is putting money na everybody can go there and get services. You only need to register with your ID and you get your services. So the other thing you'll hear, the people who are employed, unasikia wakisema tunakatwa sana. Ni kweli? Hiyo umesikia? Umeangalia ni nani anakatwa? Ama muliingia kwa wimbo ya tunakatwa sana? Kwa sababu yule mtu alikatwa ni yule akona nini? Akonayo. Kuna mtu anakatwa bila pesa kweli? Alright? But we are not looking for the facts, because when you look at the fact, you will see that, let's say for instance, una 6,000. Alright? Premium ya NHIF ilikuwa 500, sio? Hiyo ni proportion. Which proportion is that? It's 80%. Sio kweli? Unaelewana? Mtu ana earn 500, sorry 6,000, umekata 500 kama NHIF. The proportion is 8%. Hata kuwa una earn 10,000, Okay? What is the proportion? Mtu wako na calculator hiyo anaweza saidia. Unajua kama mnakuaga mkiandika lazima mjue kucalculate. 500 divided by 10,000 is 5? Is 5%. Sidio? Now, who are these people paying this money? Sini wale hawana. Ama kuna mtu yule analipa 6,000, analipwa 6,000, yule analipwa 10,000, ana contribute moja tumesoma ni 8%, sidio? Na huyo mwingine ni 5%. So ukiangalia the current NHIF, the less money you have, the more you. Unaelewana? Before mseme sijampea example mzuri, if you are earning 100,000, unalipa 1,700. What is the proportion? It's 1.7, sidio? Umelipa 1,700 na una earn 100,000. The proportion is 1.7. Yule wa 6,000 tulisema alikuwa analipa gapi? Na wa 10,000? Na huyu wa 100,000? 1 point? Weka wa 1 million. Ili muone kama hesabu, najua hata kama ni hesabu naweza kuwa sielewi vizuri, mnaweza nisaidia. The one for 1 million alipokuwa analipa 1,700. So chukua 1,700 udivide na 1 million. 0.017. All right? So it is 0.02% actually. Tunaelewana? Na yule hana pesa mlisema ni gapi? Ni 8. Na huyo mwingine ambaye hakuwa na pesa bado alikuwa na ngapi? Lakini mnaambiwa hii inalipisha pesa nyingi kuliko ile hii. Sijui kama naelewa. Hii 2.75 ni mingi ama ni kidogo? Ni mnafanya hesabu. Alright? So kama ulikuwa unalipa 8, hiyo 8 yako inatoka 8%, inakuja 2.75%. Yule alikuwa analipa 5%, inatoka 5%, inakuja 2.75. Lakini hawa watu wanalipwa hiyo pesa ni wale wanyonge, si ndio? Hao ni wale unadanganya, mtachajua pesa nyingi. So the narrative out there is that SHA imeongeza contribution kwa sababu imesema 2.75. Now, when you look at Kenyans, vile Kenyans wanaani pesa. Unajua kuna watu wako hapa wanaweza kuwa wanaani pesa nyingi. Unajua no, economists kama mimi unaangalia vile mtu amevaa, unaelewa vile mtu amekaa na unaangalia kiatu, unajua huyu mtu anaweza kuwa akilipwa pesa nyingi. Right? So kuna watu wanalipwa pesa nyingi hapa na kuna wanalipwa pesa kidogo. Now you see, if you remain with the old NHIF, watu wale hawana, they pay a higher proportion. Ndio unasikia watu sijui wanafanya kazi flower farms, kuna washman, kuna watu wa house, kuna watu wako kwa factory zile wako huku chini. When you count those people, 1, 2, 3, 4, 5, 6, right, in numbers, among the employed, you will see the people who are getting a premium deduction, wale watalipa pesa kidogo, they are around 60% of the employed Kenyans. Hiyo kama tunaelewana? Watu wale wameajiriwa, around 60% of them, their premium will reduce between 8 to 2.75 mpaka yule ako 40,000 pale ita reduce with a 0.01%. Those people ndio wengi. Ama unafikiria watu wanalipangwa pesa nyingi sana? Unajua ukiona watu wakipita na magari, unaweza fikiria watu wote wako na gari. Si unaona kama vile Nairobi inajaa jam. You might think everybody has a car, ndio? Lakini wale wanatembea na wako kwa matabu ni wengi kuliko wale wako nini? Kwa hizo magari zimeleta jam. So what am I saying? I am saying that within the SHA system, the employed people who we have been made to believe that they will be paying more. Those paying more are the 40% who have been paying less. But those 60% who have been unduly disadvantaged by the system, wanachajiwa pesa nyingi zaidi in terms of weight, their contribution will reduce. Lakini yule mtu yake ina grow, si akona pesa, tumesema huyo ndio utamkuta parliament. Unaelewana? Amekaa chini akisema pesa imeongezwa, si ndio? Ndio anaweza lipa broker kama 6. Waseme tumeongezwa, si ndio? Lakini hawatasema wale 60 wamereduciwa. Kwa sababu wale hawana, wao walienda shamba kufanya kazi yao after getting the deduction. So by the time you see these narratives, there are also groups that want the narrative to look the way it is looking. Ultimately, yule mtu watasafa ni huyo tumeita Mkenya ambaye anapata lower incomes, because they will be made to believe that shida ile inasolviwa ni yao, lakini si yao, kwa sababu wao premium yao imereduce, lakini wale premium yao increase. The 40% of the Kenyans that are employed will make us lose an opportunity to help those who have less incomes. Unaelewana? So what I'm saying is, that is number one. Number two is that the NHIF as currently constituted, watu wamekuwa wakitoa pesa. Na wakitoa pesa, unakuta kwamba the benefits that they have been giving have been either lower and concentrated to some few people. Lakini if you want to steal money from NHIF, tuseme wewe kwa mtu anataka kuswindle NHIF, all right? As it has happened over the time, you need wewe mwenyewe as a provider, hospitali, daktari, lazima ukuwe na mtu mmoja kwa huko nje anataka kuiba. Huyo mwingine wa kuiba kwa wapi? Lazima akuwe ndani. How do you steal something na wewe uko nje na unaiba kitu iko ndani? Right? Now, and that's what we argued, that for us to be able to protect the new system, we need to clean up the people. Sio kweli? Lakini hao wamekuwa wakiiba nao wakiwa nje. Si mtu akiiba anapatishana nje. Hiyo pesa iko nje, sinafanya kazi. Sasa utaona inemelipalipa watu wengine wakupiga makelele. Sababu hawataki system icheck. Sababu yule mtu ako ndani akitolewa, utaiba aje ukiwa nje? Unaelewana? Now what you need is insight. So when you see a lot of opposition towards reforming the old NHIF, is because the status quo favors some population. Na hiyo population imekuwa ikitumia hela vile inajitajirisha itself. Alright? And then is when we looked at the biometric identification for NHIF. You know, when you go to facilities, unawekelea kidole ili ujulikane ni wewe umekuja. But all our 5 fingers, not 5, kuna watu wako na 5, lakini zangu ni kama ni 10. All our 10 fingers, they are the ones nilitumia kuchukua ID. Ama kuna mtu amebeba za wenyewe? Ni zako hizo ndizo unique. So when we compare the biometric of NHIF na biometric ya ID, all right, we realized a quarter of them are not matching. Sijui kama tunaelewana. Si mikono yangu should always match. Wherever I go, it should be the same. But when I compare my biometrics, zile ziko huko ndani, zimekuwa zikilipa NHIF, and the clean ones based on the ID. Najua hiyo si ati sisi tumechukua. Hiyo ilichukuliwa wakati ulikuwa unachukua ID. Hata huko umejua kuiba. Wakati huo every baby is beautiful. Si unajua hivyo? Umeona mtoto sura baya kweli? Kila mtu akiwa mdogo anakuaga beautiful. Hajaanza kupata mashida za dunia. Ukute sura iligongwa akikunywa vitu akagongwa. Sasa sura imeharibika. So before you don't get to that level. So when we compare the biometric of the ID na ile NHIF ilikuwa inatumia, a quarter is not matching. Hiyo inakwambia aje? Na hiyo ndio watu wanatumianga kuclaim, si ndio? So you are saying there is a lot of money that might have been swindled because of fake data. If you don't clean that data, then you move to the new system with the same problems like the NHIF was actually having. So when you hear watu wanauliza kwa nini msichukue watu tu muweke huko, sasa utaweka vidole mbaya na mzuri pamoja. So when you must do a clean up if you are serious. So we said tuangalie vidole, wale watu ambao vidole zao na zile za ID zinalingana, migrate wale. Hawa wengine 3 million ambao vidole yao hailingani, hata wewe kama unataka kuchange, can you transfer those people? Tafadhali waregister tena. So ukiwa na mtu akipiga makelele, kwanza huo unajua ni wa aina gani. Kama ni wala wa kuiba, ukisikia haonekani anasema sana nilikuwa huko ndani, nilikuwa NHIF, anaweza kuwa ndiye alikuwa party ya vidole yake ndio baya. Right? Now when you have fake fingerprints, you lose a lot of money. Because somebody can admit you when you are still here. Kama hivi umekaa hapa, wewe ukuwe umeadmitiwa mahali kwa hospitali. Na unawekwa maji na uko hapa bado. Right? Na uwekwe maji siku 3 na ya 4 upewe dawa utoke ya 5. Right? Na huyo mtu alikuwa amekuadmit. Si anatumia vidole yake na ndio anasema ni yako. They discharge you. But what happens to the money? Hiyo facility inapata hiyo pesa. Ama kama wewe ni watchman na unakaa karibu, unapitia mahali ukienda kazi asubuhi, unajicheck in. Right? Nasema nimekuja, unaguza pale kidole, umeadmitiwa. Alafu unaenda kupiga watchman yake pale. Usiku 2, 3, ya 5, unapitia hapo, unakuta mwenye hospitali akona supermarket, unabeba sukari. Unaenda nyumbani. Well, these are not things I'm cooking. These are realities we have already seen. Right? Mtu anaenda niko na supermarket na niko na hospitali. Naenda unakuta amechukua pesa ile, amekuja amejicheck in, ameenda mahali ingine, amekaa siku 2, 3, mwizi hataki kuiba siku nyingi sana. Kisikia mtu amekaa mwezi mmoja, huyo ni mgonjwa wa jua. Mwizi anatakanga siku 2, 3 kwa sababu normal length of stay in a hospital is 3 to 4 days. So anakaa siku 2, 3 namna hii, anakuja and then he checks himself out. But because they need also to benefit from the dhagari, then they also do what? They carry some vitu za nyumba, sukari na chakula kadhaa namna hii, then they go home. So what I'm saying is that we are trying to clean up a system, but the narrative that is pushed out there, because if this system work, it will be among the most progressive systems ever. Now, the last thing I wanted to say is that the healthcare agenda has not come with this government. It would be lying if we say it has come with this government. Back in 2003, wrote the same laws we have written. Right? That was under Mamangilu. And that law went through parliament and got to Kibaki. And Kibaki asked, he was an insurer then. He wondered, how will a strong social insurance compete with a private insurance? That was one of the main reasons why we lost it then. Because a strong social insurance, it is public, it can give better benefits than a private. That one, everyone should be able to see. So he was scared on that level. Then in let me begin from independence. 1965, we established what we used to call the National Hospital Insurance Fund. The H in the middle used to be hospital. 1999, we changed the H to health. They became National Health Insurance Fund. Right? But in that time also, it was made compulsory, but there was no way of implementing it. So it remained like that. Uhuru tried to implement universal health coverage also. Unfortunately, he did a pilot. And the pilot was a pilot of everything. You kama mnajua definition ya pilot. You know, if you want to pilot how different people dance here, we cannot tell everybody to start dancing at the same time. Sindio? Ama namna gani? Sababu hata hakuna prefect. Na hakuna wa kucompare. There must be a methodology through which you pass through the evaluation. But 2019, Uhuru did one thing that was very nice. He established a panel of experts on what we call the NHIF we want. They wrote a good report called HEFLEP report. For those who like reading, I lecture at the university, so I assume people like reading, but sometimes I know if you don't want people to know anything, just write it. They will never know. Right? Now, that HEFLEP report, if you get a chance to get it, it's a public document. You would go and check what had they said about the NHIF we want. And then you compare with what the president is trying to do now. Right? You will see that is the report that projected that in 2022, NHIF will collapse. All right? That was 2019. They projected in 2022, NHIF will collapse. The NHIF we have now has a debt of 30 billion owed to facilities. It is technically insolvent. It does not exist. It's technically insolvent. The debt was more than the incomes or the revenues that were expected. So then, whether the change was to come or not, we will still be worse off. And that is why the majority of the noise you hear, facilities complaining, they are not driven by the problem of SHA. It's actually the challenge of the past NHIF to pay the debt owed to the facilities. And the facilities are saying, you need to pay us something so that we are able to continue providing service. Because 30 billion is not 2 shillings, right? Have you ever written a billion and counted the zeros? All right? 30 of them is no joke. So then what we are saying is that this government, at least from the healthcare system when we look at it from, have made a commitment to repaying these debts so that the facilities are able to provide services. All right? And this month they have been paid. I think it's 4 billion plus something, 4.5. I think they are being paid another 4.5. That will be 9 billion. You're just seeing that the government is prioritizing putting money in health. So there is much that I can say because, as I've told you, I have spent my life teaching. Nikianza kuongea ndaongea hivi ukutani jioni. But thank you very much. We'll be happy to hear some questions, concerns, things that are not clear. But one day we will not cure this issue. The most important thing is that we should continuously seek information. I'm sure within your system, there must be a way, a feedback mechanism. Ili swali ikiwa ngumu, true north. Otherwise, mtakaa kama matatu. Matatu unaweza ona imeweka indicator ya kuingia pande hii. Lakini inajua itaingia wapi? Itaingia huko. So to allow us to have the right signal, please let's also be able to ask questions when necessary. Thank you.
Thank you very much. A round of applause for both doctors.
Kwanza Daktari Thuranira na Daktari Mwai na vile vile bosi wetu wa masuala maalum kutoka afisi ya Rais. Nafikiri wameeleza kila kitu mkasikia moja kwa moja. Yale yanayosema na vitu kwa ground vilivyo. Mimi nataka niwahakikishie kitu kimoja. Nimekuwa nikienda mashinani hadi hospitalini, engaging with wananchi one on one. Na mengi ambayo tunaona katika mtandao, maana sababu tuko hapa, ni tofauti sana na vile mambo yalivyo kwa wale ambao wanapata huduma. Hasa mara nyingi badala kushindana na mtu kujaribu kumuelezea hashikanishi, wanawaambia nenda hospitali. kuwa mgonjwa, nenda hospitali. Ndio utajua tofauti ya SHA, kujisajili na kutojisajili. Hebu kwanza niulize, wangapi wamejisajili hapa? Wangapi wamejisajili vizuri? Wangapi wamesajili watoto wao na bibi zao? Ajipigieni makofi ya ukweli, maana bila hivyo hatutawasaidia, si ndio? Maana I want you guys to be so confident. Mkitoka hapa, you can tell a person, you can convince them from the experience that you have gone through while registering for SHA. Ndio mtasema unaniambia kitu ambacho wewe mwenyewe umejisajili. Leo ukimwambia ni kweli, hata nalipa 300, si ndio? Ama nalipa 100. There's one who's in the system, si ndio daktari? We saw analipa shilingi 100 for whole year. Imagine after doing the means testing, you're only paying 100 shillings per year. How much is that? Is it 5 shillings or 2 shillings or a shilling? Or some cents per day if you manage to pay that way, but you still get the services. I have seen Kenyans, I've experienced, because my background from politics and media, I have seen Kenyans suffer. I have seen Kenyans bleed to death kwa sababu they are not able to access medical services at the emergency. Lakini with this SHA, imagine ukitoka kwa barabara hapa, God forbid, mtu wa pikipiki apite na wewe. Kitambo leo ukifika hospitali unaambiwa nini? Lete insurance. Lete pesa kwanza. Imagine tunachukuliwa hivi, you can call for an ambulance, uje ubebwe, upeleke hospitali. The first 24 hours, it is free treatment, including kama unahitaji surgery. We save your life first, then ask for payments later. And I see it's working. But those are the stories that we've not been able maybe to tell properly, especially to the young generation. They only go with what they see on social media. But it's interest. It's custom made to attract or trigger a particular emotion. But now mmekuja hapa, mimi nawashukuru kwanza. Now we get to meet face to face. Na tujuane, alafu tuwe aligned. What are we selling? What are we telling Kenyans? So kweli ni kwamba SHA is real. SHA inasaidia. It is not a scam as people are saying. People are benefiting. We are now at 14 million. So you want to tell me 14 million Kenyans wote ndani ya SHA hawajui kitu gani wanafanya? Ni yule mmoja pale kwa Twitter ambaye anasema hii kitu ni fake. What about the 14 million Kenyans? What about the 14 million Kenyans? And that data is real. Si kitu tunafanya ukarabati. It is happening. Kenyans are getting the services. Ama mother, wangapi hapa ni wamama? Ama wazazi? Yes, we know what it means when a child becomes sick. We know what it means when you guys, our children, some of you, become sick and we have no money to save you. So you need to register. Tell your sisters, your families, your neighbors to register so that now they get to benefit. Maana hii ndio raha ya kulipa tax. Tunalimwa sana kwa mtandao kwa sababu ya taxes, si ndio? Now we have a solution. When they talk to you about the taxes, tell them register for SHA and start winning, benefiting from the taxes that you've been paying. And finally, because Muthuma will also say something. Huyu ni jamaa wa ghetto, anaongeanga vitu zingine huwa sielewi. Two extremes. Kiswahili Mombasa na ghetto mtaani. Akiweza kuzungumza I get lost. So kumalizia ni kwamba wangapi wako na WhatsApp groups zao? Mbali na kuwa na mitandao ya Twitter, Facebook, Instagram. Wangapi wako na mitandao yao? We are like 100 here today and I know there is more. You can imagine if each one of us, wala umetoka Bomet, Mombasa, wapi, we can have 2, not even 5, just 2 WhatsApp groups where we can invite other people and then we use those platforms to communicate the information that Samteri is always sharing. You just reshare. The good thing, when you have your own personal WhatsApp group, you're able to respond, you're able to guide and shape the narrative. So kindly, mbali na kuwa wababe katika Twitter, Facebook, Instagram, naomba vile vile muwe na mitandao yenu ya WhatsApp. And I'm glad Dennis Itumbi yuko hapa. He will explain to you the value of having or being an admin in your own WhatsApp group that is very interactive. Because number one source of communication on digital platforms in Kenya today is WhatsApp groups. So let's move the conversation from the misinformation on Twitter to where it matters, because every Kenyan today, each one of us belongs to a particular WhatsApp group. Now you can imagine if each one of us tuko na 250, hii message tutakuwa tumemaliza, si ndio? But thank you for coming, and please feel free to ask any questions. We are here to answer them, and don't be afraid. Watakucharaza leo, at least wamekufuata kwa page yako. And then there's that fear. Watahama. Here after 2 days they cannot stay without your content. They will follow you back. So you post. Huyo akitoka mwingine anafanya nini? Anaingia. Na akikuja sana, unamblock. Baada ya siku mbili anaanza kulia. Mbona umeniblock? Unamregesha. Amelearn funzo. Si ndio? But thank you. You guys are doing amazing. Thank you for all the support you've been giving us. Even when it was so impossible and difficult to support, you stood with us. And we really, really appreciate, and we don't take that for granted. Tutafika. Hii safari ndio imeanza, na sisi ni wale hatuendi mahali, si ndio? Tunawaambia hatuendi, wataingia lakini watatukuta huku, watatoka, sisi tuko ndani. Mudhuma, ingia wewe, usifanye mambo ya kaptengele, ndio zako hizo.
Dr. Thuranira, Dr. Moi, asante sana. Wenyeji wa kikao hichi, ndugu Dennis, asante sana. Josiah, thank you so much. Wacha nianze tena ni repeat jina yangu, naitwa Gabriel Mudhuma. Mimi na Mwanaisha tuko ofisi moja. Tunajiita Deputy Government Spokespersons. Ya kwanza wacha niseme nimelearn vitu mbili. It's what we are up against. And they say, when you know better, you do better. Menisikia hapo? When you know better, you do better. In the next 10 years, mkikubaliana na mimi daktari, I think the biggest problem we are going to find ourselves in is misinformation and disinformation. In fact, today many people are unable to define their reality. Unasoma kitu unabelieve mazeni hii. So many young men and women, ile kitu tunafanya siku hizi, na hope tutaingia hapo, ni assumptions. Profesa wangu kitambo akati nilikuwa shule, profesa wangu nikifanya masters aliniambia, Gabriel, assumption is the lowest level of knowledge. Assumption is the lowest level of knowledge. It's actually akin to guesswork. Imagine, ujui mtaani tulikuwa tunahitaji ya kifa la mang'aa. Tunasikia hiyo jina. Sunday nilikuwa mtaani. Mwanaisha upenda sana saa nyingine tukiongea hiyo lugha. Nilikuwa mtaani, kajamaa fulani kamlevi kakanikujia. Nikamwambia, Mudhuma wewe, nilisikia ukibonga story ya hii kitu inaitwa SHA. Na hii kitu si poa. Nikamwambia kwa nini? Kaniambia, unajua NHIF ilikuwa inadu poa. Nikamwambia, ulikuwa na NHIF? So unajuaje ifanye? Mimi nilikuwa na kadi ya ubatizo Mudhuma, lakini nikamwambia, so unaargue nini SHA na NHIF? Haujawahi pata, you know? So we continued talking, but at the end of it, I realized it is the kind of misinformation that is going around. How do we create a narrative that is factual? And there's something Deno started a long time ago. This system of fact, ikuanza hii yao last year. But what it became a source of really knowing what is truth or what is truthful. Dr. Moi ametuambia hapa what we are against. And so what we are against, mimi nikuambia vile na understand this story, number one, we are against a lobby group that is very well funded. Na amewambia wale watu wana fund is a misinformation. You have real people, you have real accounts behind this disinformation for very good reasons. Hapo ndipo wa dibre yao inatoka. Mimi hata mali natafuta dibre yangu kukuja kuharibu tutakosana. And I'll say so many things whether they are true or false, so that nisipoteze wa dibre yangu, ni kweli. And that is what the world has taught us. But utakuta mtu amesema sita lose hii kitu nachukua at the expense of somebody who will need that particular service. And that's the true ignorance of our society. That's what we are facing today. Jambo la pili, we have a media really that imekiuka sheria hata za wanahabari.
SPM Buzz.